In this final talk, I'm going to focus on the long-term treatment of first episode psychosis. Let me start with this question, which every psychiatrist or anybody who treats schizophrenia will need to answer in almost every case of a first episode patient. Will I need to stay on these drugs for the rest of my life? This is not such an easy question to answer, and let me sort of focus on addressing it. This is from a study in Scandinavia, which looked at populations of patients 10 years after a first episode. And these are numbers of patients, not percentages. But what you could see is that there are a substantial number of people who 10 years later were in remission and off medication. I don't think that these patients need to stay on antipsychotics for all of their lives. There's a high likelihood that they should stay on antipsychotics for at least the first 2 or 3 years. And if they haven't reached a really complete remission, it may be a good idea for them to stay. But for those who are in a real remission, it's unclear. There's other evidence that's come from studies, such as this from Lex Wondering. They followed up the results from a long-term study. In the first 2 years, first episode patients were randomized to having dosage reduction or regular dosing. If you had looked during the first 2 years, those who had dosage reduction had higher relapse rates. You would have thought that dosage reduction is a mistake. But when you looked in the longer term, there was evidence that dosage reduction led to higher recovery rates and higher functioning. And there was a population in this study, 17 individuals who discontinued antipsychotics and were functioning well. So there's a proportion of patients, some people have suggested as high as 30%, who will achieve a clinical remission and can do well on a low dose or without long-term antipsychotic. There's also evidence that staying on antipsychotics for a very long time can change your dopamine system. There could be some kind of upregulation, and maybe relapse occurs as patients withdraw from medications. That's an argument to make someone lean towards stopping antipsychotics. There's the other argument that people who are stable and staying on antipsychotics tend to derive the most benefit from psychotherapies and rehabilitation. And relapse after a first episode is associated with high rates of suicide and poorer psychosocial adjustment. These are the considerations that people who are imagining schizophrenia, patients and their families, need to consider as they make decisions about antipsychotic medications. There are important arguments suggesting that patients should be treated on the lowest dose of antipsychotic possible. If you monitor patients carefully and then supplement them if they're becoming worse, you can prevent episodes. Most studies of treating patients just until they recover and then stopping treatment have shown intermittent treatment doesn't work very well. But that's in groups of patients. I've seen patients in my clinic who are able to see when they're getting worse, and they can be treated intermittently. But an important thing to emphasize is that treatment for these populations should be collaborative. There should be a process of shared decision-making where clinicians, patients, and family members, if the patient wants them brought into the discussion, should share the decision about what antipsychotic to be on, what kinds of treatments are necessary. So what I've tried to emphasize in this final section is that we do know that planning long-term treatment for first episode patients should include using the lowest effective dose of an antipsychotic, and that patients and their clinicians should have careful discussions on the risks and benefits of discontinuing and lowering antipsychotics. Thanks so much for your attention during this series of talks.